Welcome to The Kick, your expert-led podcast helping you explore and learn everything about getting pregnant, pregnancy, birth and becoming a parent.
On the podcast and our online pregnancy program, Grow My Baby, we share my experience of helping more than 4,000 babies to be born.
And our experience of running a women's health clinic and parenting 4 boys.
We're here to help everyone to feel empowered in pregnancy and birth with real-life practical information.
Welcome everyone, I'm Brigid Maloney.
And I'm obstetrician Dr. Patrick Maloney.
And today we're actually recording on a super special day.
It is an important day.
In our annual calendar.
It is St. Patrick's Day.
No. It's our wedding anniversary.
It's our wedding anniversary.
Yeah. Which is hilarious because my maiden name's O'Sullivan and I married a Maloney on St. Patrick's Day. Pat, I thought we could just share with our listeners something about our wedding day. And I thought I'd ask you, what was your favourite, most memorable thing that happened on your wedding day apart from marrying me?
Yes. Well, I remember one funny thing that happened. We had a very fancy caterer, and they made all these beautiful little entrees.
It was a feast, wasn't it?
Absolute.
Just kept coming.
Absolute feast of really good, really good food. And one of the little hors d'oeuvres was called steak and chips or something. But
yeah, that's right.
It had a little tiny piece of beef inside it and a little wafer of potato. And I went over to the kids' table and I said to the kids, "You all having something to eat?" And they said, No, we're waiting for the steak and chips. I said, I think that was it.
It was more of a homage.
An homage to steak and chips, and which I said to them, I said, I think it was more an homage to steak and chips, and I've never seen more blank faces. Like, shut up.
Well, I'm still waiting for the steak and chips.
We're waiting for the steak and chips to get here.
Yeah, and we're like, oh, what, the quail wasn't enough? No, it was very, very fancy food. All right, not that you asked, but my favourite my favourite memory, I got so many from our wedding. It was just such a beautiful wedding. And for listeners, first-time listeners, it was my second time around and I didn't think I would enjoy it. Oh, no, I knew I would enjoy it, but I just didn't think I didn't think that, like, you know, it was so different. It was so much love in the room. Anyway, one of the things also that listeners may or may not know was I was 5 months pregnant. And
yes.
So I was the only non-drunk person in the room, and we were in this venue that actually didn't have an end point. So we were still dancing at 4 a.m. in the morning. And as a 5-month pregnant woman, I was still dancing. I'm very proud of myself. Yeah. So as the only sober person in the room, I not only had to lock up, but I had to get our DJ back to Melbourne and order him a cab because he had no way of getting back to Melbourne, and he just sat plonk on the steps of the venue saying, "Well, lady, I don't know what you're going to do about it, but I got to get back to Melbourne." But my most favourite was saying goodbye to everybody, then you and I going to the Fancy Craig's Royal Hotel at 4 a.m. and you giggling and you not being able to take your own shoes off. So I'm like,
I don't remember that bit.
Gosh, I hope this isn't the sign of things to come. Here I am, 4 a.m., 5 months pregnant and untying your shoelaces while you're giggling. It was honestly one of my real joys that I just still keep that memory very close.
A very, very happy day.
So today, Patty, we want to talk about and share Jessie from Mamma Mia, her birth story of her twins.
Yes.
Now, we have done stories before that we've moderated, which has been great, and we know that stories about birth are so popular. People love listening to stories about birth, and we don't tend to do many because, that's the domain of other podcasts, but we try to do educational content.
Yes.
And stories are a personal account.
Yes, and that's fine. A personal account is fine, and to listen to the story purely because it's interesting or entertaining is also fine. But we try and pull the educational gems out of the stories that we hear so that we can use that for teaching.
Yeah. And so there's a couple of those in Jessie's story. I'm going to give a bit of background. So Jessie and Luca are expecting their second baby, which happens to be babies. It's a twin pregnancy. And she's been sharing it on the Outloud podcast the whole time. So people has just been waiting with bated breath how she's going to have these babies, these twins. And she tells her story on the Outloud podcast, and I thoroughly recommend you go and have a listen and then come and have a listen to this. And then you can say, oh, what did that actually mean? So we're going to pick up the story at her waters have broken at 33 weeks. So the first thing that we wanted to talk about was the use of steroids in her pregnancy.
And met me at hospital. And they had, by that point, they give you steroids, which kills.
What's the steroids for, Jessie?
So the steroids are to develop and strengthen the baby's lungs.
Right.
And so they give you steroids. They take 24 hours to kick in, and they love to give you 2 doses if possible so that the babies can breathe when they're born. So they had checked to see if I had started dilating, and I hadn't. That was one of the most painful parts. I hate that speculum shit. It really hurts. They did the steroids. They started on antibiotics, and then they give me something to stop labor, essentially, to go, how can we slow this down? So they gave me some drugs for that. And that morning, as I was laying there, one of the doctors came in and said, you could be here till 37 weeks. I was 33 weeks and 2 days. And she said, if we can stop this and keep them in, we will.
Because the theory is they're better to be in there. Right.
Yeah, they're better to be in there. We don't want them out yet. And I was going, oh my God. Like, because once your waters are broken, you're on bed rest. Like, you can't really go for a walk. I messaged a few friends about it, and one friend was like, you're allowed to secretly want them out. Like, don't feel guilty for thinking, I don't think I can lay here in discomfort and pain with a toddler at home for 3.5, 4 weeks, waiting for these babies to grow and grow. I mean, it was irrelevant what I wanted because my body was going to do what it was going to do. And my obstetrician was like, you know, we keep them in as long as we can, regardless of how everyone feels about it.
They're not giving you a choice about that. It's just that you're going through that in your head. So they can't stop it forever. It's like holding back a tide.
Exactly. If your body wants to deliver these babies, they will deliver, but they can try and slow it. And that's what they were trying to do. The thing about the steroids is that if you have gestational diabetes, it surges your blood sugar. So all of a sudden, I'm finger pricking every hour. I am being filled with bags of insulin, which I hadn't had to take up until that point. The eating was a nightmare. The hospital doesn't have a gestational diabetes meals that are appropriate. So everything I ate had to be brought in, and I could eat a salad, and my blood sugar was just the worst it had ever been. So that was horrible. And again, I'm going, this could be weeks and
4
weeks of this.
Yeah.
Yeah. And then 24 hours later, they're like, great, you're still pregnant. We're going to give you more steroids, and we'd love this to have 24 hours to work. And my obstetrician came in, and I just cried and was like, oh, come on, this is really, am I going to sit here? And he said to me, the chances of you still being pregnant at the end of this week are so minimal. Like, every day you have a 50% chance of just going into labour.
So, Pat, could we just talk about the use of steroids in a premature labour like this, and follow on with how does that interrupt or impact your gestational diabetes and your insulin levels?
Sure. So this is really quite standard stuff for a baby that is, or babies that are likely to come early. So, for example, it's 33 weeks, typical classic time for the waters to break in a twin pregnancy. But most of the prematurity related to twins is that's just nature. It just happens. And I think at 33 weeks of twin pregnancy, the belly's probably getting up towards as big as it wants to get. It's already bigger than a term singleton pregnancy by that point. And the water's a bag full of fluid, and it'll break. So gush of fluid happens. The woman comes into the hospital. And because we know that by far the most likely thing to happen in the hours or days following the waters breaking is that the labour will come. And one way or the other, those babies coming out. then we can prepare for that by giving a dose of antenatal steroids. And sometimes people misunderstand. This is not steroids like anabolic steroids. It's not to make the babies bigger or stronger. It's cortisone. It's just cortisone, and it goes into the woman's arm down through her body, down the cord into the baby. And in the baby, a shot of cortisone has a very well established effect at causing the lungs' maturity to accelerate. And so the babies will come out. As long as they're born a day or so after the steroids are given, the babies will come out with a real benefit from that antenatal steroid, and the lungs come out much more like a 35 or 36 weeker than a 33 weeker. And that has a massive benefit for babies from survival to decreased time in the nursery to better respiratory function in early life, all sorts of known benefits. Just like cortisone does for anyone with diabetes, it makes the sugars way worse. So if you've got insulin-dependent diabetes and you go on a whole lot of cortisone to treat some other medical condition like your rheumatoid arthritis or your asthma, then it'll have an effect on the body sugar metabolism and how much insulin you need. So if we look at something like a twin pregnancy where gestational diabetes is much more common and prematurity and the need for cortisone is much more common, then those things would quite commonly go together. So when a woman's got gestational diabetes and it's non-insulin requiring, she's likely to be going just fine, managing the sugars by eating well and exercising. But you throw the cortisone in there and suddenly that control is no longer possible. And then insulin's required. And again, it can be hard to know how much insulin you need to give. So sometimes in that first few days, the woman might wind up on something called a sliding scale where several times a day the sugar's being taken and a variable dose of insulin is being given according to what the sugar is at that time. And that all sounds like a colossal pain in the bum, which it is, but in reality, it's not required for long because the baby's likely come out soon one way or the other anyway, and and then of course once the babies are out, the gestational diabetes goes away anyway.
Okay, Patty, you said that she gets an injection into her arm, and Jessie said that it's painful. Yeah. Why is it painful?
I'm sure I don't know. You have to have it in your arm. I'm sure you could have it anywhere, but it's big. The volume is big. Yeah. So there's a lot of. It's like a big injection. Yeah.
Right.
There are 2 reasons to subscribe to Mamamia before April 1. The first is you get 25% off an annual subscription. And the second is you also get 25% off Nala underwear, all of it, inclusive sizing, wire-free support, and the best strapless bra, which means, finally, you'll only flash people on purpose. There's a link in the show notes to become a Mamamia subscriber. What are you waiting for? Hurry before April the 1st.
All right. Now I want to pick up Jessie's story about when she starts talking about her waters breaking.
And every time I have a contraction, more water, because that's the thing, my waters were breaking the whole time. I didn't know this.
Oh, wow.
Your waters just refill.
No, they don't.
Doesn't make sense. It doesn't make sense.
Yeah.
Because
But isn't the sac broken?
Where? That's my question.
That's so. I didn't know that either. When you told me about the waters breaking, I thought, well, that's that. But
that's that.
Yeah.
And that's why I thought they had to give you antibiotics, because I'm imagining that I'm just flapping open.
Yeah.
Yeah.
Just got
flapping open
right?
with
no protection.
poo, wee, baby substance.
Yeah.
Like, who knows?
Isn't someone going to do a poo and then it's going to – but they did a scan on the Sunday and they're like, oh, yeah, they're both floating in amniotic fluid. And I was like, but the amniotic fluid is in my socks. Like I can see it.
All over the bed.
Doesn't make sense.
I don't understand.
It's like, where does snot come from? It's the same question.
Women are incredible beings.
Mm-hmm.
It just keeps filling. And it was twin A. It was boy who had broken his sack. I have a theory Margot did it, but he broke his sack.
I love these women. Like, I listen to Outlouders probably 3 times a week. Every single thing that they produce, I'm listening to.
Nice.
So I feel like they're my buddies.
Okay, good. Good. You could be around this table.
Yeah.
And you could be saying, well, most of the fluid in the 3rd trimester is fetal urine.
Yeah.
So it's come through the baby several times. They wee it out, fills up. Then they eat some, swallow some, goes through their system.
They're swallowing amniotic fluid.
Yeah.
Yeah.
And
okay,
then
nice.
it goes through and then they turn it into wee, just like we would turn anything we drink into wee and wee it out again. So it's circulating like that.
Yeah, right.
And if you make a little hole in the waters, you don't have to make a very big hole for a real trickle to happen, especially if there's no presenting part in the pelvis. So remember with twins, you might have neither bum and neither head right down in there in the pelvis. So it's not making much of a plug. Exactly. So a tiny hole in one of the sacs would leak out a fair bit of water. But then occasionally that can reseal. And women with ruptured membranes who have not yet met criteria to be born. The babies are fine. Not too much water's coming out. There's no sign of infection. We might watch those women for months. You know, if you have a leak in the waters at 28 weeks, but everything's fine, you could have that baby at term. 12 weeks later. So don't often get that far, but you could. So we look at how much water's around the baby, but if the baby's just on a wee, there'll seem to be lots. Yeah, and then the little hole. Sometimes they just keep on leaking, but sometimes it's a little flap that'll sort of seal itself.
Oh, she was right when she said, "I'm just out there flapping."
Yeah. So there's if the flap heals itself. Remember, the cervix isn't dilated much at this point, so there's every chance that the leak is further up, and it might just seal over. And then antibiotics are used because infection can get up from the vagina up into the water around the baby. But it's not because of the way baby's weeing or pooing. The baby's supposed to be weeing, and that's sterile. And they're not supposed to be pooing. That's abnormal.
When they said that baby would be pooing, that is abnormal, isn't it? Yeah.
Absolutely, yep. And they're not supposed to be pooing. And even if they do, it's still sterile. So there's no bacteria in the gut of the fetus. So that their poo doesn't smell like poo. That smells from the bacteria, and it's not infective. Yeah. So we would be worried about a baby that had done a poo on the inside, but that would be because it's a marker of poor fetal condition.
Yeah.
Not because it's infective.
Yeah. And that's that black meconium, isn't it?
Yeah.
Good. Well, I hope that clears it up for everybody, because everybody in that conversation
was really surprised.
Were really surprised that their waters can refill.
Yeah. And that's not surprising at all. So if somebody has an obvious gush and then we do the little vaginal test where you can get some of the water and test it and prove that it's from around the baby and not, I don't know, urine or something, then you do an ultrasound the next day and there still seems to be a fair bit of water around the baby. That's normal. Yeah.
And in actual fact, you kind of want to see that, don't you? Because that means the baby's healthy if they're having a good urine output.
Yeah.
Yeah.
And also that if they've got a decent amount of water around them still, exactly, that they're making urine. So that's a sign of a healthy baby. But also that there's still plenty of water around that baby to allow free movement of the limbs. And that's where healthy musculoskeletal system is going to come from, because the baby has to be able to move. And also, if there's still plenty of water around, that's where healthy ongoing pulmonary development, lung development will come from as well.
Yeah, right. I am researching at the moment about a condition called tocophobia. It's fear of childbirth. I know you know that. I'm just saying that for the rest of the listeners. And for some people, knowing that their baby's amniotic fluid is basically their urine they're fearful of that. So I'm just saying that if anyone's listening to that and feeling quite disgusted, this is pregnancy.
Yeah, right. Yeah. I think amniotic fluid has its own smell, but it doesn't smell like a grown-up's urine.
Yeah.
Or even a child's urine. Because to a certain extent, the smell of our urine might have something to do with what we're eating or drinking. And the urine from a fetus it's basically serum, isn't it? It's just like their blood that's coming into them, and they have blood circulating, and they're making urine out of the liquid component of that.
Yeah. That's a really nice thing to say, Pat. I hope someone who's listening to that and thinking that it's disgusting, it's not like your human adult urine.
No.
And it's the beginning of all the bodily fluids that will happen.
It's where we all came from.
We all came from. All right. I want to go on to where Jessie starts talking about how her birth changes rapidly.
Rapidly, yes.
I have 1 hour. And Luca was sleeping at home. So I had to call him and go, you need to get here right now. We're about to meet them.
And you tried to call me because I'm usually up at the crack of dawn with Matilda, and that is the one morning she slept in. I'm so mad. I wanted to be there.
Were you scared, Jessie? Through all this time, are you like scared?
Yeah, I think I was. I was really scared because I was also trying to decide up until that moment, like I could have gone, let's get him out vaginally. That was also an option. But I was getting advice from very clever, very considerate, very sensitive doctors. We do not know what twin B is going to do. Twin A, we reckon he'll come out in a second because he's head down. Twin B might spin. She might
and crawl
right
her way back
ribs.
up towards your like.
Yep. And what we know about twin B is that she's the smaller one. She's not very robust because they're early. And once a baby has descended into the birth canal, it is coming out the birth canal no matter what instruments we have to use. So if you want, and if she hasn't descended through the birth canal, then we do a C-section and you end up recovering from 2 births. And that is, I was given about a 1 in 5 chance of that happening. So I went, all right, what do you guys think I should do? And they said C-section. I went, great.
So things turned around really fast for Jessie, didn't they?
Yeah, so this is what happens in a problematic scenario like ruptured membranes, twins, gestational diabetic 33 weeks. There's a lot going on there. And sometimes people are really surprised that 1 minute we're happy to sit and wait and literally the next minute we want to get the babies out. And it just represents, I think, the evolving nature of the situation. So we don't want babies to come out any earlier than they need to. And we're constantly asking ourselves, is this baby better off in than out? So the answer at 5 p.m. might be in, definitely fine. Let's do some fetal surveillance at 7:30 p.m. after dinner. You put the fetal heart rate monitor on at 7:30 p.m. and there are signs on that the babies are no longer well. Well, we're not sitting on our hands for another minute. IV line, theatre, anaesthetics, section done. And in the scenario, and sometimes things evolve very quickly. Someone's in the hospital because they're at high risk of bleeding, but they're not actually bleeding. Then they do, so we act. Yeah, and in obstetrics, that things can change very quickly. They're not always evolving things that evolve over days or weeks. They might evolve over minutes. So if you're ever experiencing a complex pregnancy and you're recommended for observation in the hospital, that's not an old style thing from 100 years ago where they say, "Oh, we'll put you in a hospital and have a look at you over a few weeks." No, to warrant a hospital bed these days, it's because we know that something may evolve so quickly that we want you right there and then, so we can whiz around and have the baby if we need to.
When the nurse is there and she or he's doing the obs, what are the things that they're looking at?
Well, in a ruptured membrane situation, we're on the lookout for infection at all times. So, for example, if somebody's pregnant, they've ruptured their membranes, but they are not in labour, then it's perfectly reasonable to stay pregnant, not deliver, and wait for more gestation unless there's evidence of infection. And this is another one of those things that can change very quickly. So in the morning might be fine. 10 a.m. Develop a fever, need immediate delivery. So babies will go all right if we get them out at the first sign of trouble, of infection, but extremely poorly if they come out badly infected. So we act immediately. And we don't sit around waiting for the woman necessarily to develop a really high fever. We might have missed the hours beforehand that are important. So we would be looking at other more subtle signs like the maternal heart rate, whether she's got any pain. Having an infection in the uterus is painful. And those things will sometimes tip us off to a developing chorioamnionitis, an infection of the membranes, placenta, and the water around the baby before the woman even develops a fever. And it's just a truism in obstetrics that if you've got any evidence that is happening or even might be happening, then you're better off getting the babies out because any benefit from another half a day of gestation will be totally wiped out by the risk to the babies of being born infected.
And the decision-making around why it went straight to caesarean and not a vaginal birth.
Yeah.
Can you talk about that?
Yeah, that's an interesting one because often that decision perhaps has already been made or is in the process of being made when suddenly all of this extra stuff happens. So I always think about vaginal birth of twins as needing to meet certain criteria to be safe. And I think a lot of people would be looking for gestation a fair bit more than 33 weeks. Yeah. So historically, the poor outcomes for twins have been related to how well the second baby goes. The first baby tends to come out okay, but the second baby can get a bit lost on the way out with all of the extra room and can often present sideways or feet first or and have complexities relating to getting that baby out. And so if you add all of that to the risk of being premature in the first place, it can tip us over a threshold we're all comfortable with and we might be more likely to recommend a Caesar. So I think this proceeded according to, pretty much what would be usually recommended. It's just that if there was still a question around vaginal birth, it may be because that hadn't been fully decided and then suddenly fate intervenes, waters break, and it all becomes more urgent and more risks involved in compounding the potential risk of vaginal twin birth with the complexity of only being 33 weeks. Same pregnancy, no ruptured membranes, might have gone on another 5 weeks and certainly been suitable for vaginal birth. Yeah. So that's another thing that can happen when fate intervenes and things get complex is sometimes all that time we thought we had to make up our mind about these things can go off the table pretty quickly.
Yeah. And as people go back and listen to Jessie talk about it, she only had just finished work.
Yeah.
And either that night or the next day, her waters broke. Yeah. So, she thought she had lots of time to pack even, let alone think about
and so often busy working people have left those things, setting up nursery and getting all the...
You think you've got all this time. What else am I going to do with my time?
Washing the clothes, people have given you all those sort of things for this magic time at the end between finishing work and having the baby, and then suddenly the baby comes straight away.
Yeah. Or in my case, in my first pregnancy, I finished at 36 weeks but didn't go into labour until like 41 and 5 days or something, so... I had way too much time on my hands, so you just never know, do you? The unpredictability of birth.
Quick question. Are you tired of the news? Do you want a podcast that isn't self-improvement? Come get unleashed. It's funny.
I also think that underwear is sort of almost like a new marriage. Like it starts off, it gives you the best of what it offers at the beginning.
It's unhinged.
I have a bit of a thing for my friend's husband's salami.
Oh, hello.
It's not here to teach you anything.
I need to make sure he looks at me. One side, I'm going to make a sign. This is what I married because I didn't meet you in time.
Yeah, right.
The other side, with pointing to my son who's 12. Look what we could have had, Lewis.
Yeah, I love it.
It's a good time for Gen X. So search Unleashed wherever you get your podcasts. New episodes every Tuesday.
All right, I want to finish with something that pertains to us, but like they are hilarious. They go on and talking about lots of different things that I think people would find really interesting. But we're just really focusing on some education points. And the next one I want to focus on is placenta rummaging. Let's talk about that.
Go to them, check that they're okay. And I was laying there and started feeling really bad, like lightheaded, nauseous, out of it. There's no way I knew I'd just had 2 babies. And then the anaesthetist, I could hear the obstetrician saying, whatever you're giving her, you need to give her more because the placenta wouldn't soften. There was an issue with the placenta. I heard them say that I'd lost a fair bit of blood. And the anaesthetist then said to me, I hate having to do this, but I'm about to give you some drugs that are going to make you feel really bad. Like they're going to make you feel really sick. And basically when you have twins, like the two placentas, I think were like hardening, like they weren't soft enough to get them out. So I could feel them. And then I turned to the anaesthetist and I was like, I feel really sick. And he said, it's a mixture of the drugs and the rummaging. Like you can feel that rummaging.
Yeah.
And actually when Margot came, so they got Harry, and then it felt like the obstetrician was sitting on my ribs. The strength he had to use to get her out. And he later told me that it was like they were little fish that were like swimming in circles and he was trying to catch them.
She's like, don't get me, don't get me, don't get me. And it's like,
don't get me, don't get me, don't get me. Which I was like, I'm very glad you came out the sunroof.
I
didn't need to play chasing
no
in the birth canal.
All right, so many things there. So firstly, what would the anaesthetist have given her to make her feel sick?
So we commonly use medication to try and get the uterus. So this is after the baby's out, right? Not beforehand. So the babies are out, and then the uterus won't stop bleeding until it's clamped down, and it can't really clamp down unless the placentas come out neatly. So we often give medication to try and get the uterus to clamp down harder.
And does an anaesthetist do that?
They give all the medications.
Oh, right.
Yeah, because we're up in the scrubbed area, the sterile area. So it's the anaesthetist who's got access to the intravenous line. Yeah.
So more syntocinon, is it?
Yeah, well, we use syntocinon usually for augmentation of labour or sometimes for third stage. But more often for third stage, we'll use a medication called Syntometron, which is a combination of syntocinon and a drug called ergometrin, which is a really powerful contractor of the uterus. So at a Caesar, we'll tend to give a standard shot of a long-acting version of syntocinon, and that will take care of most of the time. But if there's still too much bleeding and too much trouble and too much difficulty getting the placentas out, then we'll use this drug called Ergot, and it really makes you spew. It causes intense, very, very unpleasant nausea and vomiting. So it's a really great drug. It's a life-saving drug. If you've got to use it, you've got to use it. But you'd rather not. It's nice to be in a situation where you don't need to use it in the first place.
She talks about placenta hardening. Is that just actually her feeling her uterus harden, perhaps?
Yeah, I'm not sure quite what she's describing there. I don't think the placenta is any harder in a twin pregnancy than a singleton pregnancy. Certainly placentas can get hard when there's high blood pressure, preeclampsia, those sort of things. But more likely, I think there was a problem with uterine tone and therefore the uterus was bleeding too much, and they were doing all of this to try and fix that. It's a very, very common and standard, very common thing to happen with a twin pregnancy because the uterus has been overstretched and it doesn't contract very well if it's so big. Yeah. Imagine any other muscle in your body. If you stretched it out to be twice as long as it usually was, then it wouldn't contract very well. And that's what tends to happen with twins. So this type of postpartum hemorrhage, needing these fancier drugs is a really common thing to happen in a pregnancy where the uterine muscle has been overstretched. So twins, triplets, big baby, or excess amniotic fluid, so-called polyhydramnios, where all of the muscle has been overstretched and doesn't contract very well when it needs to. And, because the postpartum hemorrhage is the everyday emergency. Like it's not rare. It's just that we've become very, very good at managing it over the years.
And, we've done it before, an episode on it before, but it's not rare also in cesarean section, more uncommon, but it still can happen.
Yeah, right. And the rummaging, poor old, the rummaging that she was feeling. That's an episode. Firstly, to get the babies out, and then to get the to get the placentas to come out, and it is, I think, very unpleasant for people. Excess rummaging, and it's.
Is there a better term?
I don't know, but I think
Pressure.
that it's because the spinal block is excellent at blocking pain. but it doesn't really block pressure. It doesn't block a feeling that someone's rummaging around on your insides. And once we, people think maybe the cut will hurt. Well, the cut never hurts, but once you're inside, and if you have to rub the outside of the uterus a lot to get it to contract, when it's empty, when the babies and the placentas are out, then it can feel very unpleasant, sort of a deep pit of the stomach unpleasantness that isn't well blocked by the spinal.
I think from my 4 cesareans, that feeling is the only thing that would be very similar or slightly similar is when you're really anaesthetised in your mouth and a dentist is pulling a tooth. If you've ever had, I had my wisdom teeth done in the chair, but like it's sort of like that really deep sort of pulling and pressure feeling. And I remember that from my cesarean sections where you did feel like the obstetrician was on your tummy, but they're just putting a lot of pressure in and it's an unpleasant feeling. For me, didn't last too long.
Sure.
So, and it's the feeling after the baby's been pulled out. Like it's just like it feels like it's a suction.
Yeah.
Like a plunger is just, you've taken a plunger off the plug hole or something. Like it really, it's a feeling that you don't have any other way to describe it because it probably never ever happened to you in any other way apart from having a teeth pulled. So she then finishes with saying that once the first twin was out, the second twin sort of did move around a bit, described by fish circling around in a uterus, just like you said.
So that uterus hasn't contracted yet, right? Because it can't, because the second baby's still in there. So there's all this sort of extra room, and then that baby problematically will often stretch out and move around and wriggle. And sometimes it's convenient that the head of the second baby will come straight up towards the Caesar cut, and that's great. You just break the waters on the second sac and squeeze that baby's head out the same way you did the first. But it's common with the second baby to grab them by the feet and bring the second baby out as a breech extraction, even if the baby wasn't in breech position.
Right.
That can just be, feet are easier to grab than the head.
Right.
And if you grab the feet, you can hold on. And then they can wriggle all they like, but you've got them, and then they'll come out.
Yeah, wow.
Even a twin Caesar, it can be challenging, and it needs a lot of training.
Well, I highly recommend. We have done a twin pregnancy podcast before, and we've had mixed. Mainly positive reviews on that. Oh, thank God we listened to it because that's exactly what happened to ours. We've had 1 or 2 people over the years, doing this for 5 years or so now, that have said, look, it's all bad news in our twin pregnancy podcast, and we've and ahed a little bit about redoing that twin pregnancy podcast, but again and again and again, people say that is exactly how my pregnancy went. I had my babies at 33 weeks. We went to the special care nursery, or we went to NICU. It was an emergency cesarean. It was, so.
Yes.
Yeah.
Look, I think that is really true, especially of multiple pregnancy. It's, I think, to fully understand what the value of the interventions are when it comes to multiple births, you have to understand how poor the outcomes used to be before scientific principles were applied to the process. There's no doubt, if you look at a healthy young woman having a single baby one at a time, that plenty of people don't need intervention. But if you look at multiples, pretty much everybody needs some intervention if we've got any hope of getting the data for twins or triplets to be anywhere near as good as the data for singletons. And I always think that's where we should be starting. Yeah. So I think it is realistic for parents of, where the woman's pregnant with twins, to be expecting some degree of intervention and medicalisation of the pregnancy and the birth. More so, much more pressingly so than if there's only one baby. And when I talk to people about having a normal vaginal birth of twins, I hesitate to use the word normal because it's actually a highly interventional, highly medicalised birth.
Yeah.
If you want the safety data that we can provide by doing that.
Yeah.
Yeah.
Good. Well, I think Jessie's story is great listening, even if you're not pregnant with twins. They go on and talk about their journey after the twins were born and how they went to NICU and then special care nursery, but then Margot, the girl, had to go back into a NICU situation and moving hospitals and how that's been a week on, and what their job as parents basically they say is just to go and cuddle those babies, and how beautiful and respectful the NICU is. And
there's a lot of good listening there for people.
Yeah. So go and have a listen. Come back to this and see if you need further explanation of a few things, and we hope that's been useful for you today. All right, everybody, that's all we've got. Until next week, when we're back in your ears, have a great week and keep growing those babies.
Thanks for listening, everybody.
Okay, bye for now. Hey, even though Dr. Pat is, well, a doctor, and we get lots of other doctors and other experts on our podcast, I just need to remind you that this podcast is for informational purposes only. We share lots of medical insights and experience, but everything we talk about is general in nature and may not apply to your specific situation. Please always consult with your own healthcare provider for your individual medical advice when you grow your baby.
Want to feel good more often in 2026? Hi, we're here for you. Move by Mamamia helps you fit movement into your everyday, giving you more of me time whenever you need it. From strength and cardio to yoga and Pilates, with workout plans that fit every space, every body, and whether you've got 10 minutes or 40. Start 2026 with enjoyable movement from just $9.99 a month. Mamamia subscribers get unlimited access. Head to move.mamamia.com.au and use MoveMe to get $20 off an annual subscription.